Hi, good morning, everyone, and welcome in. We are so glad to have you with us this morning. Thank you so much for being here. My name is Zane May. I work with Wichita State University's Community Engagement Institute, and I'm going to be helping to make sure that we don't have any tech issues or problems using Zoom. So if something comes up for you, feel free to reach out to me in the chat, or you can also send me an email. I'll make sure to drop my email in the chat for you. We have an hour here together, and we're being joined by Jane King, who's going to lead our presentation. So, to make sure that we have time for that presentation and any questions or comments that you have after, I'm going to go ahead and hand it over to Jane to get us kicked off. Thanks, Jane.
Awesome. Thank you, Zane. So, good morning, everyone. I just trying to quickly look through the participants today. Hopefully, some of you recognize me. I know tons of folks in Kansas because I love Kansas. And so I'm really excited to be here today with you to talk about building a data-driven CCBHC. So I know you guys have been, many of you have been running for a while. You've got things figured out, but boy, this idea of being driven by data seems a little odd to us clinicians, I suppose. So let's talk about it today, and I'll get us through our slides. So, first, you saw the title slide. Whoops, I have a tendency to flip the wrong one. Okay, there we go. So a little introduction of me. I used to work for the National Council for Mental Well-Being, and that's when I got to know many of you. And I was laid off in June, and now I have started my own consulting practice. So if anybody's looking for help, I'm here. So I've been a clinical psychologist for 30 years. I've provided most of the services or supervised them in CCBHC. I worked for the state of Minnesota for 5 years, and then again at the National Council. And while at the National Council, I worked closely with the state of Kansas as they were establishing their state plan amendment and their services getting started. So exciting that they're in the demonstration now. So my information is there. Feel free to reach out, check out my website, see what you think, and we'll get moving on the agenda. All right, so I know all of you know CCBHC, but I'm going to do a quick overview just to sort of highlight some key points that help get to this idea of being data-driven. Then we'll talk about some of the elements of that and then talk about what we're going to do tomorrow. All right, so hopefully this is very familiar to you. I talk a lot about the foundation of the model being a three-legged stool. So it is the integrated clinical model, which many of you are deep into and figuring out how to implement all these new evidence-based practices, et cetera. That's the piece that we all hear about all the time. And so that's really key, but I think we don't always talk about the other two pieces of, or the other two legs of this stool, I should say, that are so key. So the second piece, sustainable funding, I think you're probably all very aware of how helpful that is and how important that is to be able to do this full model. But the green leg of the stool, lots of folks get a little mixed up in this part, the quality measurement piece. And I think it's because, I mean, straight up for 30 years, we've been providing services and filing claims fee for service or measuring, getting grants and just counting how many people we've served. And that's great. That has gotten us to where we are. But now it's time for us to look at, are the people we're serving getting better? Have we increased access to care in our communities and our service areas? How do we know that? And the only way to know that is if you're actually measuring these things. So there are obviously measurements that come with the model, but there's also things you would do as well. So that piece, then again, hopefully you are all in and out of this criteria 67 times a day, much like I am. And so you know all of these pieces, but I just want to sort of remind you that section 5 is where we talk about, or wow, where SAMHSA, I guess, more specifically talks about quality and other reporting. but it feeds into every aspect of this criteria. Every section of the criteria has a piece that needs to be thought of from a quality measurement standpoint. So, staffing, obviously, you've done your needs assessment. You're trying to figure out if you need to add more positions, if you need to add more staff. And that's all relative to what you discovered the need was when you did a needs assessment. Availability and accessibility, we all know a big piece of this model is there are a lot of people in this country who are not getting the behavioral health services that they need, and many folks on Medicaid who don't even realize how the what opportunities are in front of them. Sometimes it's language barriers, cultural barriers, things like that. And so doing your needs assessment, figuring out who's in your community and are their needs getting met is that quality measurement piece, or I should say, it's what sets up the quality measurement piece. And then into care coordination, think clearly about care coordination because the wonderful piece about it is that it's there to help people get the services they need and access to services and getting their housing set up or figuring out if they're getting the benefits that they need. Are they on food support? All the social determinants of health that are such a big piece of how people get better at your CCBHCs. Care coordination is also the place where you've got a whole group of folks whose job is to keep you organized and keep the people that you serve organized. So they're a huge piece of how you keep track of things and how you set things up and make sure they're getting done on time. So think broadly about how care coordination helps with quality measurement. Section 4, scope of services. Obviously, there's tons of services you're implementing that you've already had, that you're putting in evidence-based practices, those kinds of things. Again, you want to be measuring how well those things are doing in your particular service area. Quality obviously is there, and then organizational authority. And this piece is important because accreditation has been added. So there's an opportunity for individual clinics to receive a CCBHC accreditation from an accrediting body. And by doing that, you're sort of establishing that we are meeting all of the federal requirements of CCBHC. And the idea here is that you would be able to walk into a CCBHC anywhere and get this high level of service. So I think the accreditation is important for that, but it's also depending on what organizational authority or governance you have, it does make a difference in how you're able to collect data, report on data, what data quality systems do you have in place. So it does play a role in quality as well. And then there's some links at the bottom so that you can look at the criteria, but there's also a little shameless self-promotion. But when I was working for the National Council, Renee Boak, another consultant, and I put together these 30-minute videos explaining each section of the criteria. So highly recommend. And there is even a particular one about needs assessment. We talked about scope of services. Again, in here, I'm throwing this out there to remind you what they all are, but also to get you thinking about quality measurement, outcomes, being data driven. If you think about crisis services, there's so much data that you're needing in order to determine need for crisis services. How many staff do I need to have? What are the hours? Where are they located? How do they get to people? There's a lot of numbers that you're pulling in there. And so I want you to acknowledge that you're already data driven if you set up a crisis program. Um, when doing primary care screening and monitoring, that's something care coordinators or other folks on your staff are doing. It's a way to collect information about the people we serve and then use that information to get services or to get additional services that they might need. Um, Peers are a wonderful support to the people that you serve, of course, but they also can really help drive the programming of your CCBHC and collecting information. And then serving veterans, obviously, is a very important piece of this model. And there are ways in which you might be tracking things so that you know whether or not you're accessing the veterans in your area or if they're in need of your services. Just a reminder about how the prospective payment system works. I'm just putting this in here because hopefully you all know this formula, but it's all the allowable cost for a year divided by the total number of visits in that year. So clinic specific, cost based. But remember, there are all sorts of allowable costs that Kansas has agreed to within Kansas's CCBHC program and are generally allowable according to CMS. All things that will help you be data driven. Because I gotta say, one thing for me as a psychologist, I'm not really a numbers gal, as you can kind of imagine. I often am saying, I was told there would be no math. But I'm learning that it's absolutely crucial to be able to do the work that I do well is to understand what's working and what's not. And so I think a big piece of CCBHC is getting clinicians and administrators and receptionists and everybody who works in your organization, all your assistants and et cetera, um, to be thinking about how things are working. So know that there's so many pieces where you can get help with this. I'm not a data analyst, but boy, would I love to hire one, right? So know that under these allowable costs, under staffing, think about data analysts, as I said. Maybe you've got a peer who's really interested in data and they can start to put together some models for you. Think about your clinicians if they do like data, but also knowing that you can hire people who focus on the data and they don't have to be your clinicians trying to do 16 different things. Know that your electronic health record is the backbone of your integrated care. And so that's where you want to be making as much updates, as many updates as possible, in order to be able to collect the data and report on the data that you need. Obviously, your quality measurement program is all under your PPS or allowable costs, and thinking about who's collecting, who's reporting, what's in the EHR that allows this information to be collected and reported. And then CQI. So we're going to talk about CQI in a bit, but know that these are allowable costs. So these should be things that you can build into your PPS so you can afford to do these things and not have your other folks who aren't data oriented trying to just sort of figure it out as they go. Know that outreach is allowable. Outreach is an opportunity to learn a lot about your community. And so you might do a needs assessment in the beginning. Then, as time goes on, you're doing some outreach and discover, whoa, there's a whole community in my service area that hasn't been coming in and still isn't coming in. Let me do some work to figure out what's missing there or what they need and shift things to accommodate that. I talked about care coordination. Know that care coordination generally and um, in particular for Kansas, that care coordination does not have a specific billing code, right? So it's something the cost of which is built into your PPS, but you aren't necessarily collecting that PPS when providing care coordination. What that means is if there's no definition of care coordination for the billing, meaning saying that you need a particular type of provider or a particular type of person or all the eligibility criteria is um, not as important because you're not billing a specific service at that point. That means you have a wide open field of what you would consider care coordination in your organization. So this is often where data analysts are hired or folks that are able to move people through an intake process to make sure that you're getting all of the information about them that you need, et cetera. So be thinking about care coordination. And then, of course, DCOs are under there too. So there might be some situations where you are getting data from other organizations that go into your data. And so doing that work back and forth to make sure you all understand each other. And if you want some more information about this, do go to the CMS webpage. You know, often people go to the SAMHSA webpage and see the criteria and things like that. But the CMS webpage is actually really informative about the financial pieces of this model. All right, so now I want to introduce this idea. Oh my. Oh, okay. Sorry. I was thinking, oh my gosh, I'm talking too fast. But I'm not. I have plenty. Oops. Um, so Quality measurement model. We want to think of this as a constant cycle that's going on all the time. So it isn't, we need to get started, therefore we're going to do the community needs assessment and then boom, boom, we're done. Let's put it away and we're just going to move on and do our work. That's not the point of all of this. You're doing that community needs assessment just to establish how you're going to start, what's missing at the beginning of your CCBHC. But it doesn't end there. It's stuff that you're learning about all the time as you're working with people. They're letting I really need help with this, and you guys don't have that. Or I I have these needs that you aren't fulfilling, and I just don't know if there's any providers in the area who even do this. Maybe someone needs eating disorder treatment, so you're going around to find eating disorder treatment in your area if you're not able to provide it. So you're constantly learning about what's working and what's not in your community, and you want to keep that information and use it to update your needs assessment because that's how you'll justify needing new things in your program based on what your community needs from you. So again, you do it at the beginning so you can establish, but then you're always updating it so that you have a clear picture of who's in your community. Then from that needs assessment, you think about, okay, we're just getting started here. And it looks like when we've talked to people in the community that we don't have enough substance use slots in outpatient, or we have a high incidence of eating disorders in our community, and there isn't an eating disorder provider. So we're setting a goal of establishing an eating disorder program as part of our CCBHC, or maybe your I don't know. I'm trying to think of a million things, but you already know them, I'm sure. But you're figuring out what's needed, and then you're establishing goals for yourself. I want to fill that gap. I want to make sure that the people in my community are coming in. So you set some specific goals for your overall CCBHC program. Then you get into the weeds and dive in and develop this whole thing and get it going based on what your community said they needed and the goals that you set for your organization. So develop all of this and then immediately, actually within it, as you're setting goals, you can be setting measures of those goals. How will we know that we're reaching those goals? So you set things up as part of your development to answer the questions that you need to answer based on your goals and your needs assessment. So again, there are quality measures that the federal government has put into place for the demonstration, but then there's also clinic specific or even state specific goals that have specific measures connected to them. So just get it in your head, this thought about, I wonder if we should blank, do some information gathering, find out, oh, indeed, there is something that we want to do here, set that goal, and then set up a measurement that tells you whether you're reaching that goal. Then, once you've got all that in place, you've got CQI, continuous quality improvement. This is where the rubber hits the road, right? This is where you take that needs assessment data. You've got the goals, you've got measures that you've been pulling data from, you've got reporting, got all this information about how things are going. You need to have a forum in which to process and determine what to do with all of that information. That's what CQI is. We're running all the time doing these things, and we also need to be looking at, is it working? Is it getting better? Are the people we're serving getting better? Are more people coming into our clinic who haven't been here before? Or if they're not, why not? So CQI is where this cycle just keeps going throughout the whole time that you're a CCBHC. You should never stop asking questions about your programming and if it's helping the people you intend to serve. So I throw this in because sometimes there's clinicians in here who are learning about all different aspects of CCBHC. And for me, as a psychologist, what really made it hit home for me in thinking through this sort of data-driven model and this needs assessment concept was the assessment and diagnosis process for seeing a person, right? So somebody comes to the clinic and says, "Hey, I want to get some help." So they sit down with a clinician who asks a whole bunch of questions, finds out, oh, there's all these symptoms and issues. And from that, I can form a diagnosis and then present that to the person. This is what I'm seeing. This is how it seems to be coming together. What are your goals? Where do you want to be? And they determine, I want to do this. I want to get a job. I want to, do whatever it is they're trying to do. They set those goals. Then immediately the clinician is thinking about, okay, so then what do I need to do to help them reach those goals? What are the interventions I'm going to provide? Which evidence-based practices am I going to use? What are all the things I'm going to do to help this person reach their goals based on their assessed needs and their diagnosis? Then I'm going to do the treatment, and all throughout the treatment, as a clinician, I'm constantly measuring in my head, is this working? Are they reaching their goals? Are they getting closer? Are they getting further away? I think I need to sort of reassess what's going on here because maybe I missed something, or maybe I'm finding out that, oh, there's also a substance use issue going on that I didn't know about at the beginning. Okay, that helps. Now I know more. And so we can be talking about that and start to update goals and interventions based on what we're discovering as we go along. Then from that, I'm going to, as a clinician, think about, okay, that worked for this person. Did I learn something here that I could use with other people that I'm serving? Wow, this might be a pattern. Okay, I'm going to do some CQI and sort of figure out, could I have done better? Could I have moved them faster? Could, if I had known about this other piece, how do I find out about that other piece, etc. You're just always thinking about how can I be better? How can we serve people better? And how can I know more about the work that I'm doing? All right. I'm going to take a breath. You guys can take a breath. I'm going to have a little water. And now, so we've talked through sort of all this conceptual idea of being data driven, these cycles that we're going through where we're gathering information and acting on that information and then measuring whether those actions worked. In order to do all of these things, there's all these pieces in it. We looked at that wheel. And so now I'm just going to kind of go through all those things that were on that wheel to talk about what they are individually, and then we'll talk about how they fit together. Okay, don't be alarmed. This looks really crazy, but I'll tell you what, I spent hours and hours and hours and hours and hours with the criteria. Um, and certainly since 2023, when it was updated and there was considerably more information about how to do a community needs assessment, um, I just started to think about what are all the things we're trying to do in a needs assessment and what parts of the needs assessment accomplish that. So if you think of just overall a community needs assessment and then go down this hierarchy, the next level is there's a whole part of community needs assessment where you're just trying to get at the demographics of the people who live in your service area. So, how many people did we serve last year? How many people do we think we're going to serve when we start providing this, that, and the other? Um, what are the populations in our area that we should be targeting that either have been coming in or are not coming in? Looking at language and culture and, language including people who are deaf and hard of hearing and, just really trying to understand who is here. Then, based on who is here being your service area, and then for the state being the whole state, um, so the next piece, we know who they are now, but what do they have and what do they need? What are some things they've already got? So you've got all these services going. It seems like people are really utilizing them. You have a good idea of what's working. What you're really trying to get at in this needs assessment is what's not working, what's missing, what's really needed. So this is from that information you're starting to put together your staffing plan. Which evidence-based practices do you need to employ in order to serve the people in your community? What care coordination partnerships are you looking for? Or are you going to do some DCOs? Because there's some services already existing in your area that are really good and you don't need to like double up on them. Um, so then from those service gaps and barriers, you're thinking about, okay, how am I going to increase access? Over in the demographic section, I figured out that I'm serving half the people in my service area who are eligible to be served by our clinic. Um, and I think I'm going to increase that by 20%. Well, why? Right? So it's you have specific goals that you set up for how am I going to increase access to all the people in my community so that they know this is a place to come and they feel comfortable and get their services here. So you set those goals, and then you start to put things in place. So this is a specific requirement within the needs assessment is you're needing to determine if your clinic location or locations are easy to get to on a bus route, etc. You're also thinking about the hours. Often, clinic CCBHCs, when they get up and running, they start running until maybe 7 p.m. instead of 5 because there's a whole bunch of folks who would like to get services after work or after school, things like that. So you might adjust that. There are some clinics who do some research and discover, you know what, we got to do some work on Saturdays. There's just so many people in the area who can only access care at that time. So let's do some research, figure out what those hours should be. Let's set it up. And then, of course, after that, you're going to be measuring is it a good idea to be doing that? Is it worth it to be open on Saturdays? And that's all a sort of needs assessment, goal setting process. Then the other piece that you're doing in your needs assessment is you're trying to figure out, yeah, but how are we doing so far? How have we done over the past few years? So you're looking at those numbers and you're looking at, okay, we were able to do this, but now that we have the sustainable funding and this integrated care model that includes care coordination, huh, I think we can actually move the needle on some of these outcomes that we've been struggling with. And so you establish those goals and then you set up benchmarks or baselines for where you are now, right? The current outcome data. And then you can measure how far you're getting from that, right? How many more people are being served? How many more people are accessing care coordination who didn't have it before? You're also going to be looking at who are we currently serving and who in the area is not coming in. Remember, we looked at the demographics to determine who's here. This part on the far right, current outcome data, you're looking at, okay, I know who's in my community, but who's actually coming into my clinic. These people are, but boy, these people and these people and these people certainly are not. And so I need to figure out what it is they need and start to provide it. So you're going to have some population health management goals. And some of that is cultural. Some of that is, I'm sure you have a lot of folks in your CCBHCs who have a lot of medical issues. And you're not a medical clinic. CCBHC is not a medical model, but having those care coordinators means that you can really start to help certain populations with medical needs. And the people that we serve tend to have a higher incidence of high blood pressure, of heart disease, of um, diabetes, et cetera, lots of chronic conditions that are there for the people that we serve in the safety net. And so by having some goals around, I want to, you know, help. I've got a group of folks who are on antipsychotics and also have high blood pressure. How can we, bring those scores down? Or folks with diabetes and taking certain medications, how can we help them manage their diabetes? So you're thinking about all of the types of folks that are being served and then coming up with how you could serve them better and then measuring that. So, the links on the bottom of this slide deck, and you'll get the slide deck, of course. Again, it's a criteria link so that you can look at where the community needs assessment information is. So part of it is in the criteria or in the sections of the criteria. The majority of it is towards the end of the criteria where they have definitions and they have a definition of community needs assessment that goes into this level of detail. If you want some help with that, there is a TA center for clinics. that was started years ago, and there is a needs assessment toolkit that folks at the National Council designed. I highly, highly recommend it. It's very well done, and it's got a lot of the information that you need. And then again, those on-demand lessons that Renee and I did, there is one specifically for community needs assessment. So I recommend watching those just to get that sort of big picture concept of what this is. All right. The other piece that is so hugely important, and I've sort of touched on that we're looking at some populations that maybe haven't been coming into your clinic, and much of that might be based on language and culture. So there is a whole conceptual framework called culturally and linguistically appropriate services, or CLAS. There's a link in the bottom right corner there, National CLAS Standards. So you can go to the website and check out all their information. I went to the website for you, so I've got a little bit of the information here, and you'll get more tomorrow. But what it's really getting at, the heart of CLAS, is that there is effective, understandable, respective care that responds to cultural health beliefs and practices, languages, health literacy, and other communication needs. So everything you do needs to have a piece of, yeah, but is it working for everybody? Yeah, but what about this group? Are they coming in and even getting that thing met? So not only do you need to understand excuse me, the cultures and languages in your service area, or the people in your service area, but you also need to understand what it is they need and what it is they don't have. That health literacy piece is really key. One place where I have an example of that. So I live in Minneapolis, and I don't have a full clinical practice anymore, but I do assessments for people from the Somalian East African community, where I do an assessment and then I write what's called an N-648, which is an immigration form that allows people to become citizens by waiving some of the requirements because of their severe mental illness. So you can imagine most of the people I'm assessing have severe PTSD from the wartime that they've lived in. So, what's been discovered in Minneapolis, where we have a very large Somali community, is that there really isn't a lot of knowledge about mental health in Somalia. There isn't established systems, there isn't necessarily definitions, there isn't a word for depression, and there isn't a word for schizophrenia. These are conceptual ideas that haven't really taken hold in many East African countries. And so we realized in starting this work that most of it was going to be about education at the beginning, like helping folks understand that those flashbacks and those nightmares, those are part of a diagnosis called post-traumatic stress disorder. And shockingly enough, there are some treatments for it. Most of the people that I assess, everybody they know has these same symptoms and they think they just have to live with them. So it's been a really interesting opportunity to sort of break open some of those things and work with folks right at the level where they need it to help them learn how to get access to the care that they need just by knowing that it exists. So I think that health literacy is really key. So when you're using class standards, it is part of every aspect of your work. So it's part of your governance, leadership, and the workforce that you have in your organization. It's about communicating in language, and then it's about engagement. There's that continuous improvement, CQI, and accountability. Accountability meaning, have you been noticing, have you been evaluating whether you are serving folks from different cultural backgrounds in your program? So class is incredibly important as you're doing this work, and I'll give you more detail tomorrow. Um, Again, population health management, I mentioned what this is. This is just, right out of the criteria, just to sort of get this thought in your brain, and then tomorrow we'll go a little more into detail on it. But the requirement in the federal criteria is that you must have a health IT system, so that you can do things like population health management, quality improvement, et cetera, on this list. So be sure to check that out. All right, I've mentioned this, but I want to sort of make it a little bit clearer. So the idea when you're first starting out, and then you'll continue to do this throughout the time you run your organization, um, but when you're starting out, you're doing that needs assessment. It's so crucial. I've seen so many times where people think, well, here's an example. I worked in a homeless shelter in St. Paul for a long time, supervising an outreach team. And one day I came to work and there were all these, well, I came to the shelter after lunch because they serve lunch there, and there were all these sandwiches in Ziploc bags in the in the garbage cans. And I thought, that's really weird. What's that all about? So I asked some folks about it, and what it was is that all the folks that were waiting in line for lunch, they would, wait outside the building in a line until lunch started. So, it's like 10:30, 11 as they're all sort of lining up and getting ready. And while they were waiting in line, these vans pulled up that all had like a church name on the side or something, and folks came out with boxes of sandwiches and they were handing them out to people. Lovely, wonderful. Oh, love it that there was this group of folks who really cared about the folks that are unhoused and wanted to make sure they had something to eat. But oddly enough, they handed out those things to eat while they were waiting in line for their hot lunch. And so the people in line said, I took the sandwich because I just felt really bad. And then I ate my lunch and I wasn't hungry, and I don't have a fridge to keep this meat fresh. So I had to just throw the sandwich away. And I think this happens over and over and over because if that church had just called the shelter and said, hey, we want to help, what are some things that we could do to help? No one would have told them to make sandwiches. Someone would have instead said, hey, how about mittens, scarves, backpacks, sleeping bags, I don't know, blankets, etc. These are all the things that folks really need and can benefit from, but the sandwiches, not so much. So I just think it's a great example of how we think about what would I want or need if I was in that position, rather than asking the people who are in that position what they want and need. So you do all that work to figure out what they need. Then you start to set goals, and you can read these things in here, and we will go into this more in detail tomorrow as well. But you're using all of that information to set your goals. Then you're developing your program based on that. And then, as we talked about, the next piece is measuring it. So this is again right out of the criteria, and we'll go into more detail tomorrow. But just the very basic minimum requirement here is that you must have the capacity to collect, report, and track encounter outcome and quality data, including but not limited to these 9 things. So this just has to be done. So may as well make it useful for your clinic and do the research, find the information, and set up programming accordingly. Again, out of the criteria, just to see that there is an absolute requirement that all CCBHCs are doing CQI plans, are completing CQI processes within their CCBHC. And so this is just setting it up as you got to do this. So why not make it work for you? Um, all right. So I did talk considerably faster than I thought I would, which is awesome. I don't usually do that. I'm usually overtime. But this is great because then it gives some time for questions or to just put some thoughts out there. Because we're going to go definitely into more detail tomorrow. But I wanted to give you guys a really solid base today of why we're collecting all this data, the requirements to collect all this data, and the requirements to do something with it. So rather than just, checking boxes that you have a CQI plan, why not make a CQI plan that works for your clinic, that helps you understand your services and the people that are being served to make sure they get what they need? So we looked at this cycle before, or introduced it in a previous slide, but now I'm using this at the end of this presentation to talk about this is what we're going to do tomorrow. So now that you've got all these basic elements of how to be data driven, or what it means, I should say, to be data driven, tomorrow we're going to start digging into the pieces of this of how do I then put it all together in a CQI plan? How do I think about needs assessment, goal setting, development, quality measurement, CQI. How does this all work in my organization? And what are all the things I'm going to be doing to make sure it continues to work and that the services continue to work for the people being served? So again, that was fast. So I say we open it up to questions. And I'm gonna stop sharing. There we go. Um, and so you have the information that I just gave you. I'd love any questions or thoughts or, oh, I see some familiar faces and names. Hi. Um, but yeah, let's open it up. What are some thoughts? What are some things folks have been doing already or some things you're trying to understand better? It was such great information that nobody has any questions now. I know you probably expected I was going to talk for the full hour, and frankly, I did too. But I was able to get through this faster than I expected. Um, so if there aren't, well, oh, hi, Michelle.
Hello. So, question about community needs assessment, and this may not pertain to your presentation, but I'm going to ask it
Sure.
anyway because nobody asked anything. With a community needs assessment, when you're putting it together, like we did one, as we became a CCBHC, but everything was jumbled then, and we have a better understanding now. So, as you're writing your community needs assessment, you have all your data, you have everything put together. How do you suggest putting a community needs assessment together? So I was looking at your slide that has the community needs assessment and all of the different pieces on it, and that looks really great. Um, do you put your community needs assessment together as like a report, written? What do you suggest as being the best way to put that together?
Interesting question, Michelle. Because, there's sort of this obvious, like, oh, you do it as a report, because that's how we write everything. But then
Words aren't always fun.
I know, right? And they aren't really engaging.
Yeah.
So I'm just thinking through, you've sort of opened up an idea that probably folks are using, but again, I'm not my specialty, but I love the idea of a living, breathing document that is constantly evolving. So it seems like, I don't know, I guess I'm going to think of it in the golden thread kind of idea. When I'm first assessing somebody and I've got to come up with a diagnosis, I need to write a very specific initial evaluation or comp eval or that thing that you do, diagnostic assessment. I need to, this is a point in time sort of thing where, like, when I first met you and learned these things, this is what I know about you today. Then that sits there, and over time, I'm doing treatment and this is evolving, and I'm like, ooh, wait, I missed a diagnosis. Ooh, wait, that's not your diagnosis at all, or whatever. Um, and you just learn and learn and learn as you move through the treatment. So I think there is a meaning to having a report at the beginning that's we did all our research and came up with these pretty little charts and graphs and things, and it told us here's what's missing. And so then from that we made these goals. I think it's nice to keep that complete, right? It's a point in time of this is what it looked like from the beginning. And it's also where you're setting a lot of your baselines, right? We know there's, X amount of people doing this, and we would like to help this XYZ amount of people do that, right? So you're setting those goals. So I like the idea of it being a point in time. So have a little report that you can sort of refer back to. But then I've seen a lot of organizations do some clever things with their needs assessment to keep it a living, breathing document. Some of it is as basic as there's a folder on the shared drive that whenever something interesting happens, people put it in there, right? Like I met with somebody today and she said that this building is being condemned and there's all these people. Okay, now we know there's a whole group of people somewhere who are needing housing supports. I wonder about their behavioral health, right? So all these things are happening and we don't think of them as updating our needs assessment, but they really are because they're helping us learn about our community. So I think having the first thing and then having a system by which you're getting information from folks, you're educating your staff about what is important information. Because I don't know, I was a case manager at one point and, I'd find out things and I'm like, everybody must know this already. Like you just think you're just doing this thing, but it really is important, and the data that you're finding out is crucial. So I think then having some sort of system where people can be reporting, or maybe you've got quality measures that you've set up that are helping you report, or you've got CQI processes that are helping you keep track of all of these things. And obviously, your CQI committee is going to be incredibly helpful too. Because I think, I suppose, in a sense, you're creating a needs assessment at the beginning, and then it's sort of CQI that is the ongoing process. But it's so key to keep using that to update your needs assessment, because a key piece here in many states is that if a clinic, way down the road in some states where they have a system where a clinic can say, hey, we had a big change in our area, there was a natural disaster, or we just discovered there's a population we haven't been serving. And so we need to implement a new evidence-based practice to, as a result of that, and maybe need more space or whatever it is, then you might write some sort of proposal to a state to say, we would like to add this in, therefore our costs are going up, so we would like to be rebased. The only way to justify something like that, and again, this is in some states, I'm neglecting to remember exactly the way it works in Kansas right now, but because you went from spa to demo too, but the only way that a clinic is able to say this thing has occurred and therefore we must XYZ is through needs assessment. It is an updated needs assessment that tells the state, oh, we just learned something and we want to take some action on it. So it's sort of long-winded. You could tell I was thinking about it as I was saying it, but I like the question.
Very helpful. Thank you.
Yeah. Yeah, and I think one more piece of that is some states have chosen to create templates or formats for their needs assessment. So, like Minnesota, for example, we set up a whole um, needs assessment template. That's been great for the clinics to get what they need. But I think what Minnesota is finding is like, oh, now there's some missing pieces. And we've sort of stopped our clinics from exploring those other pieces by telling them this is all they had to do. So there's a lot of states I'm seeing now sort of back off from a template idea, and instead we want you guys to be thinking about how do I use all of these tools provided to me in this integrated clinical model? How do I use them in such a way that really improves things and that I can bring that back around? So I think I want to compare it to primary care screening and monitoring. People are always asking, so do we provide medical services in CCBHC? No, we absolutely do not. But I feel like it's a way to get behavioral health clinicians and folks in clinics to be thinking about primary care. So often as a psychologist, I was providing care to somebody and not thinking one bit about how their diabetes or their high blood pressure or their anxiety was stressing them out and all these pieces. I just feel like I did such a disservice for many years. And so having those primary care screenings is just a way for our folks to go, oh, hold on. There's some medical stuff. I think I should get a care coordinator on this and help you get the care that you need. So I think of it the same way as a needs assessment. We're always kind of learning some more and figuring out what we can do.
I will say the template that we got from KDADS when we first started as a CCBHC was immensely helpful. But I think you're right. You miss some pieces of it, although
Right?
I think it is all the things that were in it, I think were incredibly important. And I definitely am looking at those for this needs assessment as well, just adding to it.
Yeah, absolutely. Well, and I love what you're saying about it too, that, it sets a nice tone, like, okay, this is the depth of information I need to collect, or this is where I need to go. But you've got to be curious about your own service area because, the state can't think of everything. And it's really about getting your minds deep into that data piece just so that you're asking questions and finding ways to get answers to those questions. All right, other questions? All right, well, then I'm going to throw out to all of you. I'd like to hear some examples. So I know many of you have been doing this for quite some time. Others of you are a little newer to it, but um, I don't know, somebody jump in and let's talk a little bit about what you discovered in your community needs assessment, how you're measuring that, how it's paid off for you to understand that. And if people don't jump in, I might call on my friends.
I
Oh,
could share an
Steve,
example.
I was gonna call on you.
Hey
Thank
Jane, how you
you.
doing? Well, we're kind of in the, we of course do the needs assessment every few years. We're on the, we're to start the third part of our year. So we're 2/3 of the way through our execution based on all the stuff we want to do. But one of the things that was pretty clear, we serve a 5 county area, and we cover some communities that are quite rural and even frontier. And some of the folks on the call are even much more frontier than us. But the feedback was we need more access in the communities where you don't have a clinic necessarily, or maybe you do, or you're only open part of the time. So we started thinking about that strategically. Like, there's a community called Howard, Kansas, which is a very rural frontier area, and then realistically, just it makes no sense financially or practically to have a full-time office with full-time
Right,
staff and 8 to 5
right.
Monday through Friday. There's just not enough people there to warrant that. But what we did is we used our needs assessment to think, how else could we meet those needs? We created these kind of hybrid navigator type positions that are available to do both care coordination, but they can also do a little bit of registration. They can go to some of our other clinics and open up the door if they have someone that needs an intake, and we can connect them via Zoom. So it was a good example of how we use the needs assessment to identify a need and develop positions, personnel. And we're also working on some building projects there as well. But I mean, it was pretty clear in our needs assessment. The community was saying we need more help in the places where you don't have offices, or if you do, you're not open all the time. So we've created a few of those positions, and so far so good with how that's going.
That's a great example, Steve. I love that. And I've seen so many CCBHCs kind of go through the same thing. Like, as you start providing services, you start uncovering all these needs that you didn't necessarily know about. And that's no reason to just go off willy-nilly and set up this huge program because, it's a clinic-specific cost-based rate. You could have said, we need to hire 8,000 people in order to be in all of these areas, but instead went, let me think about that. I bet there's another way to crack this nut. And so I love the idea of creating a new type of position under care coordination who can accomplish those tasks without needing a whole staff. And I've seen people start to create, like, there was a frontier clinic in Minnesota that discovered, as they were setting up care coordination, discovered that most of the people they served did not have a primary care physician and did have a chronic disorder. And so it opened up this whole new world to them of like, oh my gosh, there's almost no medical care in our frontier counties. And so we're not a medical clinic, but what can we do to help with that? So they decided to make all of their care coordinators nurses. And so then all of these folks were getting nursing care coordination. So they got all their medical stuff set up. And then as people got established into their care, then they started to shift and said, well, now we can have care coordinators that aren't nurses because we don't have that much need. Now let's have some folks who do this, that, or the other. And I think that just makes total sense, Steve, and especially the clinics who create sort of intake care coordinators. Oh man, that is streamlined, right? Some people who can just make sure everybody gets through this process quickly. That's about increasing access. So I think that's a great example, Steve. Thank you for that. And I was counting on you. Um, all right. Well, it is 9:55, so we've got like 5 minutes. Are there any thoughts or questions before we sort of close up and talk about what we'll do tomorrow? Okay. So I think people aren't asking very much because you know all this stuff. And this was such a great presentation. You got everything you needed. So cool, cool. Um, so as I said, today was really about introducing concepts and this sort of general sort of 10,000-foot view of what it means to be data driven. Tomorrow, we're going to get into the details of that. How do we start to get this data? What does it look like? how do we put it together and what elements do we use to make the right choices. So we'll be doing that tomorrow, and I'm very excited about it. And since we have like a minute, I'm going to ask a favor. I'm struggling with that. I set up my email and I sent group emails, and now my email seems to be spam. So if any of you have a sec, email me, jane@janekingconsulting.com, and just say hi, and then it'll help me get my email address to work. I know that's so lame to do that at the end of a session, but hey, we had a minute.
Jane, thank you so much for joining
Yeah.
today and presenting. Looking forward to joining with you again tomorrow. Please bring questions tomorrow. We'd love to have you get those questions answered while we have Jane and her time with us. And then, like Matt said, Thursday we'll be back with the KDAD staff. So if there's something you're wanting to get from Jane before then, make sure you ask it tomorrow. All right, everyone. Thank you all for being here. Hope everyone has a good day. We'll see you again tomorrow at 9 a.m.